Thank you, Martin. I'm very glad to be here. And my subject is metabolic conditioning, and hopefully at least some of you know the meaning of this when I'm done talking here. I have no disclosures. A key response to a key feature of the body response to injury is the development of insulin resistance. And it's, it's very surprising that a very healthy person, the day after surgery, he has become a diabetic, which is really what happens. And this happens not once in a while, it happens all the time. And you develop hyperglycemia, you have a reduction in insulin sensitivity with increased glucose production, reduced glucose uptake, affects GLUT4 translocation and glycogen formation, and etc. And dogma number one, it was, since this is a normal response, is it really bad? Couldn't it be good for the patient? And if you lived under these circumstances, maybe it would be a survival advantage. But in a modern society where you don't have to run and hunt to get food, this is not a good thing. And this is a very, very ambitious study from Montreal showing where they performed insulin clamping in 273 patients undergoing open cardiac surgery and measured insulin sensitivity. And in this study, they showed very well that with increasing insulin resistance, with decreasing insulin sensitivity during surgery, there is a marked increase in complication rates. And you can see here a 5-fold increase in severe infections. So this is intraoperative insulin resistance. And in this study, they could also show that there is an association between intraoperative insulin sensitivity and preoperative insulin sensitivity as measured by HbA1c. So if you have a worse situation before surgery, you will be worse off during surgery. And you can also say that if you have a diabetic, you really want to get him down here before he goes into surgery. This is similar to our own experience where Ulf Gustafsson published this a couple of years ago, where we studied 150 patients undergoing colorectal surgery, and we looked at postoperative glucose control. And this was within the ERAS protocol. And you can see here, this is mean levels of plasma glucose, and we measured plasma glucose 5 times daily. And so this is really postprandial levels. And what we could see was that in these 150 patients, 25% of those actually had increased HbA1c levels before surgery without a diagnosis of diabetes. So a large group of the population coming into colorectal surgery has really bad glucose control to start with. And in this group of patients, they had higher glucose levels, they had higher CRP levels after surgery, and they had almost a 3 times higher risk of postoperative complications. So preoperative insulin resistance is not a good thing. So what about postoperative insulin resistance? And this, I think the strongest evidence still is in this intensive care study from Grete van der Berge, where she studied more than 1,500 ICU patients that were randomized to either intensive insulin treatment and normal glycemia, or a more allowing higher levels of glucose and not as intensive insulin regime. And she showed very well that normalizing glucose levels were associated with marked reduction in morbidity and mortality. And this was seen also with a quite modest, the increased risk of hyperglycemia was seen also in this group of patients who had levels of glucose between 6 and 8. That is not so much. So insulin resistance does matter. And metabolic conditioning then, what is it? And it's not about preoperative optimization really, which is a process that goes on for a couple of weeks before surgery, preparing the patient. Metabolic conditioning is sort of the last minute optimization, and it's about avoiding the overnight fasting, which is dogma number 2. And this is really a nice overview that I found on Google, and it is from Sherif Awad and Dilip Lobo's paper a couple of years ago. And it shows that starvation, and also quite brief starvation, such as an overnight fast, leads to a lack of circulating substrates for metabolism. So the body needs more substrates, and then you will, to get to this, you have an increased protein breakdown, releasing amino acids that go to the liver for gluconeogenesis. You have increased lipolysis, releasing fatty acids, going also to supply fuels for gluconeogenesis. And you have higher levels of fatty acids, you have low levels of insulin, and this will make a lot of metabolic effects on mitochondrial function and glucose transport, and you will develop insulin resistance, and you will develop hyperglycemia, which goes up to toxic levels, which in turn have effects on cellular function. So there's a lot of things, and we can say bad things happening when we are starving, and I didn't have my lunch yet. But when you are just fasting briefly, if you are eating, this is quite rapidly reversed to the opposite. However, if you are in this metabolic state and you add an insult, a surgery, an injury, this type of pathways are more resistant to changes. So you will not reverse this just simply by feeding the patient, which is really a great problem in the post-operative situation. So how do we then get the patient a nice breakfast before surgery? I mean, you could give it intravenously, but then 20% glucose, you would probably need that, and you will have to put a nasty intravenous catheter into the patient. And much more easy is to provide this nice carbohydrate drink. And a 12% carbohydrate drink will give about 50 grams of glucose, which will increase insulin levels to around the same levels you have after a regular meal. And just to remind you that it has many studies, a lot of evidence showing that it's quite safe to provide clear fluids up until 2 hours before anesthesia. And this will have a lot of obvious positive benefits, of course, excluding a small number of patients. And this slide shows that gastric emptying, this is using isotope activity measurements. This is water, and this is the carbohydrate-rich drink, and you can see after 2 hours it's empty. And just to remind you that not all drinks are useful for this, because if you instead use a nutritional supplement, 400 milliliters of that, 50% will remain in the stomach after 120 minutes. We did some studies on that also. So nowadays there's a lot of data from patients in clinical studies as well as in surgical practice, and there's really nothing there's really no information that this is not a safe procedure. Using this carbohydrate loading is associated with a number of positive aspects, pretty obvious in the preoperative situation. You have reduced thirst and hunger, and also increased well-being and reduced anxiety. And in the post-operative situation, PONV may be positively affected by this treatment also, as has been shown in some, but not in all studies. But quite clearly, using this preparation and avoiding the overnight fasting is associated with quite marked reduction in postoperative insulin resistance. And as you can see, this is a number of randomized trials, and you can see that there is about a 50% reduction in insulin resistance as measured by hyperinsulinemic clamping. This is another study from Shanghai where this improved insulin sensitivity was associated with changes in the muscular level. You can see there is increased activity in tyrosine kinase, PI3 kinase, and PKB, which is really important steps in the anabolic effects of insulin. This is also an interesting study. It has a little different study design to it. It's from Montreal, and it showed in 22 patients undergoing colorectal surgery. It's a randomized trial, and they were given in total about 70% of the resting energy expenditure as a glucose and an amino acid infusion. And the infusion started 20 hours before surgery in one group or at the beginning of surgery in the other group. And the infusions kept on for 2 days. And if you calculate, it will provide around 2.9 milligrams per kilo and minute of carbohydrates. And looking at other studies, when 5 milligrams per kilo a minute were given overnight, we saw a 50% reduction in insulin resistance. So it's probably not as much, but it's probably good enough. And in this study, they could show that patients that did not fast overnight had a reduced protein breakdown, improved protein balance, decreased muscle proteolytic gene expression, and increased albumin synthesis. So a lot of anabolic effects from this. This is a UK study showing also in major abdominal surgery. This is a randomized trial with oral carbohydrate loading. Reduction in the control patients, a reduction in mid-arm circumference, which is a surrogate measure for the lean body mass, but a much better maintained lean body mass in the treated group here. This is another study which is already from 1984. Using IV glucose then, 5 milligrams per kilo a minute. And you could see a reduced protein loss, urea losses in the treated group as compared to the control group. And this study was really forgotten for a number of years until Detective Ljungqvist reopened the case 10 years after here. This is a more recent study from Denmark showing a randomized trial that patients with carbohydrate loading had a less reduction in muscle strength. So there's a lot of effects on protein and glucose metabolism by avoiding overnight fasting. What this slide shows is that if you use insulin during surgery to control glucose, to maintain normal glycemia, there is a less inflammatory response. So this is in open heart surgery, randomized trial, and you can see a less increase in IL-6, IL-8, and TNF. And this is a study using the carbohydrate load. It's not a randomized trial, but it's a quite well-matched control study. It's half of the group were quite minimal surgery, laparoscopic cholecystectomy and mastectomy, and the other half of the group had major abdominal surgery. And you could see, in association with an improved insulin sensitivity, there you can see here less increase in glucose levels. There were less increase in IL-6. So there might also be influencing the immunologic response to surgery here. This is another study pointing to this, orthopedic surgery, fasting versus carbohydrate-rich beverages, and the reduction in HLA-DR expression on monocytes. This is some kind of a surrogate measure for immunodepression was found only in the fasted patients and not in the other two groups. Also, the heart, the availability of substrate and the insulin effect has been shown to be beneficial also for the heart. Number of studies showing better cardiac performance after cardiac surgery when you provide glucose or glucose insulin infusions perioperatively. And this is a study using the oral carbohydrate load. This is from Berlin, Claudia Spies, and it's 160 patients randomized, placebo-controlled. It's ASA III and IV patients undergoing open cardiac surgery. And in the patients that avoided fasting, we had a less requirement of inotropic support when they were off the cardiopulmonary bypass. So, in summary, preoperative carbohydrate loading is associated with less postoperative increase in glucose production and protein breakdown, less postoperative reduction in peripheral glucose uptake, nitrogen losses, and protein balance. Influences lean body mass, muscle strength, and immune function. But many of those studies were done in a quite traditional perioperative setting, and you can ask yourself, is this really necessary if you have this ERAS protocol when you have the stress reduction? And I mean, carbohydrate loading is just one piece of a big puzzle here. And we have this study. It's a randomized placebo-controlled study from our group. It's Monica Svanfeldt, published a couple of years ago. And these patients were studied with hyperinsulinemic clamps before and after surgery. Glucose and protein kinetics were measured with isotopes. And what we could see was that they were all treated with the ERAS protocol. And in the group that didn't get that had overnight fasting, glucose levels increased postoperatively significantly. And we could also see that in this group, this is the clamps, this is before and after surgery, before and after surgery. It was a significant increase in protein breakdown in the group that were overnight fasted and a more negative protein balance. One good thing with stress reduction is that you actually tolerate nutrition without hyperglycemia. And this was shown by Matthias Soup before he left Stockholm for the New World. And he showed this is all patients, they were undergoing colorectal surgery. They were treated with the ERAS program. And he showed that if these patients were on hypercaloric nutrition, and this group were on full enteral nutrition. And he showed that even the group with full nutrition did not develop hyperglycemia, and they didn't have any protein losses as indicated by nitrogen balances. Interesting. So one major problem here is the diabetic patient, which is a group with a high morbidity, difficulties with management of perioperative glucose control. And we don't really know if they are in favor for this treatment or not. There are no clinical studies. We did one safety study, and it's in uncomplicated diabetes mellitus, and it was patients on oral anti-diabetics or insulin. And what we could show was, this is also published by Ulf Gustafsson, could show that glucose levels after intake of this drink were down to baseline after 3 hours. And we could not see any difference in gastric emptying using the paracetamol method. So it seems that it's time to do a clinical study in this group of patients. It really need to be done. So I think I have shown that there are a number of metabolic effects from avoiding preoperative fasting. But of course, you want to know, does it have any influence on the outcome of patients once they leave this safe environment here? And this is a meta-analysis in the control studies on preoperative oral carbohydrate or preoperative carbohydrate loading that has been done so far, and this is not published yet. It's accepted in British Journal of Surgery, and there is, if you look at the patients undergoing major abdominal surgery, it's 762 patients. There is a one-day significant reduction in hospital stay, but there is not yet any solid data on complication rates or mortality. This is a study from our own institution. It's the patients undergoing colorectal cancer surgery within the ERAS protocol, and Ulf Gustafsson will show you this in more detail later on. But what we could see was that with increased compliance, there was a reduction in postoperative symptoms and complication rates and length of stay. And in multivariate analysis, there were really two factors, two of the ERAS items that were significantly independent predictors for improved clinical outcome. And it was preoperative oral carbohydrate loading and perioperative fluid volume. So, after reviewing this, we can just say that all recent guidelines recommend this treatment, which is, I think, not surprising. There is quite good evidence that you do have a stress reduction, and it's completely harmless, and it's not very expensive. So, but are there more to be said about metabolic conditioning? I mean, than just providing a carbohydrate breakfast? And there might be. There are, I mean, you could provide other substances that have effects on metabolism or other specific effects that are beneficial for the patients. And the glutamine and arginine have been suggested to be maybe a good thing to add on to a carbohydrate loading. And there are some studies done by the Dilip Lobos group demonstrating possible positive effects from this, but it still needs to be studied in clinical studies, I think. So in conclusion, I would say that metabolic conditioning is about avoiding overnight fasting. Preoperative oral carbohydrate loading is as safe and easy as clear fluids. It reduces postoperative insulin resistance, remains muscle mass and function, remains to be evaluated in the diabetic patients, and there are probably an effect on length of stay and possibly on outcomes, although this is not demonstrated yet. I think this is an important part of the ERAS protocol, and it's recommended in most current guidelines. Thank you.